Hi everyone, we are the doctors Bjorkman. I am a pediatrician.
And I'm an OBGYN. And this week we are talking all about gestational diabetes. What is it? What's a glucola? How do I know if I have it?
Yeah, so if you're pregnant, be sure to stay tuned for the rest of this episode as we're going to be talking about some testing that you will be sure to go through during the second trimester.
Right after this. Thanks for joining us. If this is your first time meeting us, I'm Sarah and I'm an OBGYN and I am also 27 weeks pregnant.
And I'm Kurt, her husband, and I'm a pediatrician. And we thought it would be fun and also just great for everyone if we could share all of the advice we've been giving to patients over the past few years, as well as what we're learning while going through pregnancy the very first time ourselves.
Yes. So there's a couple, big appointments that happen during your prenatal care, and that first one is kind of around 11 to 13 weeks when you have that first ultrasound for your genetic screening. At the 20-week mark, you have your anatomy scan, and then somewhere between 24 and 28 weeks, you are going to have that dreaded Glucola test where they screen for gestational diabetes.
This is going to be a really big episode where we dive into diabetes in pregnancy, which is incredibly common. We're going to talk about the testing for that, what that means for you as mom, and stay tuned to the end too, because we're going to talk about how this changes kind of late management in pregnancy with extra screening needed for baby late in that third trimester. So, what is gestational diabetes?
So gestational diabetes is diabetes that develops during pregnancy. The placenta produces some different hormones like placental lactogen, prolactin, progesterone, and some others that cause some moms to become carbohydrate intolerant during pregnancy. Those hormones are very important for the fetus to make sure they're getting enough nutrients, but sometimes they can cause issues for mom.
Gotcha. As it is, about 6% of pregnant women in the U.S. will get gestational diabetes. And just like as is true in kind of non-gestational diabetes, the rates of gestational diabetes are higher in certain ethnic populations. Notably, it's more likely to be higher in women who are of African American descent, Hispanic American, Native American, Pacific Islander, or even East and South Asian women, more so than in women of Caucasian descent.
Yeah. And the numbers are increasing, which we suspect is because moms are getting older, as well as the increasing rates of obesity in the U.S.
So why do we care about gestational diabetes?
There are a lot of reasons, actually. Women who have gestational diabetes are more likely to get preeclampsia and are more likely to end up with a C-section. Importantly, studies have shown that women who have gestational diabetes are at an extremely increased risk of getting diabetes in the future, predominantly type 2. Studies have shown that up to 70% of women who have gestational diabetes will go on to get regular diabetes within 30 years of their pregnancy.
Yeah. I think it's also important to note that gestational diabetes or diabetes of any kind in mom can also put baby at risk. It's been associated with increased risk of baby being too big or macrosomic, having issues with low blood sugar after birth, having issues with birth trauma, getting stuck in the birth canal, shoulder dystocia, congenital birth defects, and even increased risk of stillbirth.
Yes, and studies have shown that fetuses that are exposed to a mom in utero who has diabetes is at an increased risk as a child of being obese and getting diabetes themselves, and that is independent of their weight or other risk factors.
Because of all of these potential complications to mom and baby with gestational diabetes, your OBGYN is going to want to know, do you have diabetes? Because it's been shown that really good control of blood sugar can reduce the risk of all of these potential consequences to mom and baby.
Right. And so that is where the screening with the Glucola test is going to come in. So most women are going to undergo screening sometime between 24 and 28 weeks. However, ACOG recommends earlier screening if you are overweight or obese and have at least one of these risk factors shown here, some of those being physical inactivity, a first degree relative with diabetes, hypertension, PCOS, a history of cardiovascular disease. All reasons your doc may screen you earlier in pregnancy.
If you don't have any of those extra risk factors, you will likely be screened between weeks 24 and 28 weeks of pregnancy, as is the standard for all pregnancies.
Yep. And so that is done with the Glucola test. Glucola is a 50-gram glucose solution that you drink. 1 hour after you drink it, your blood is drawn to test your blood glucose level. And if your blood glucose is under a certain number, usually to 130 to 140, depending on your hospital, then you pass. You don't have gestational diabetes. If your blood sugar is above 130 to 140, then you have to do another test. It's called the 3-hour glucose tolerance test to see if you, in fact, have gestational diabetes. All right, so 27 weeks, and it was officially time for my Glucola. I'm a real weirdo and like the Glucola. Throughout my time as an OBGYN, I have tried the variety of flavors, and the lemon lime is my favorite. The orange is totally gross. So if you get the orange, I'm sorry. But I looked out and I got lemon lime, shot that delicious little cocktail down, and 1 hour later they drew my blood sugar and I was under 140. I did have an attending in residency who always told us that you should eat scrambled eggs before you did your Glucola. It's voodoo, but I followed that recommendation and passed. So that was fun. I do want to say I know lots of thin people who fail their Glucola. It isn't about how skinny you are. The placenta just affects, those placental hormones just affect some women differently. And I've seen many skinny minis fail their Glucola. If you fail, you have to do the 3-hour glucose tolerance test, which is really miserable. You have to go in fasting, drink an even bigger drink, and then they check your blood sugar at 1 hour, 2 hours, and 3 hours. So there's 4 values, and if 2 of those are off, then you fail and you have gestational diabetes. So I hope for you that you pass the first time with flying colors, but know that it's common and it can be treated, and I hope you get the lemon lime.
So if you fail this 3-hour glucose tolerance test, then you are diagnosed with gestational diabetes. But if you get this diagnosis, it is not the end of the world. It does mean, though, that your OBGYN is going to want you to get treatment to help reduce the risk for all of those complications of mom and baby that we've talked about already. It has been shown, again, that with good glucose control, blood sugar control, that you can drastically reduce the risk of complications for mom, like hypertensive disorders, preeclampsia, the risk of C-section, risk of shoulder dystocia, and decreased risk for babies and things like macrosomia or big baby and birth trauma along the way with good treatment.
So now you're wondering, what is the treatment for GDM? And the answer is specific diet changes as well as exercise. If diet and exercise are not enough, then we add medication.
But what are the diet and exercise recommendations?
Well, the first step is going to be glucose monitoring. So your doctor or provider is going to want you to check your blood sugar at home 4 times a day. The first time being in the morning when you wake up before you've eaten anything or fasting, and then again 1 to 2 hours after breakfast, lunch, and dinner.
Yeah, and this can seem like a lot, but there's actually some good logs or apps that you can use for this. Something called Glucose Buddy can be really helpful. And if you're scared, don't be worried. Like, this is something that your OBGYN deals with all the time. They likely have a nurse educator or even a diabetes educator that can help you kind of learn the ropes of this very new testing and thing for you. Once your blood sugar control is under a bit better stable control, you may be able to reduce some of your testing from that 4 times a day to less often if diet, exercise is working well for you. But you should count on at least needing to test at least twice a day once you have that diagnosis of GDM.
The American Diabetes Association and ACOG recommend specific values for your glucose levels. And so fasting levels in the morning before you wake up, we want to be under 95. If you're testing 1 hour after you eat, we want it to be under 140. And if you're testing 2 hours after you eat, then you want it under 120. Your provider's probably going to want to see the values in your log about once a week. If those numbers are abnormal or above that range we're looking for, they might want to be reviewing it more frequently.
It's safe to assume that with a diagnosis of gestational diabetes, you're going to get way more comfortable checking your blood sugar levels.
Definitely.
But once you have that down, and with having that down, there's going to be all the other changes that happen too.
Yeah. So we know that women with gestational diabetes have a carbohydrate intolerance. So the mainstay of treatment is diet changes as well as exercise. The goal of these diet changes is still to make sure that, mom is getting an adequate amount of nutrition as well as baby growing and developing appropriately. There are specific nutritional recommendations for meals that we will cover right here. So studies have shown that if your diet is composed of 50 to 60% carbs, that you are more likely to have an increased weight gain as well as postprandial hyperglycemia, or your blood sugar being high after you eat. So the recommendation is to bring your carbohydrates down to 40% of your total calories. Your protein is 20% of your calories, and then fat is about 40% of your calories. It's also recommended that you get your carbohydrates from complex carbs as opposed to simple carbs. And complex carbs are things like vegetables and whole grains. Additionally, this is recommended that you do 3 meals and 2 snacks to divide that up. And your total calories that you should be consuming is going to be based on how tall you are, your current weight, and your current BMI. And that is something that the diabetes nurse educator or nutritionist will go over with you when you're kind of making this new meal plan.
For women who are overweight or obese with gestational diabetes, moderate intensity activity is recommended to help improve blood sugar control. And so these recommendations are 30 minutes of moderate intensity aerobic exercise at least 5 days a week, or 150 minutes per week in total. You can also walk for 10 to 15 minutes after each meal, can help bring down some of that postprandial, post-meal high blood sugar levels.
So the big takeaways for exercise are walk for 10 to 15 minutes after each meal and get 150 minutes of exercise, moderate intensity, every week.
Yeah, and that 150 minutes a week goal may sound really familiar to you. As we talked about exercise in pregnancy back in the first trimester.
Yep.
You can see that video linked here. And this we talked about pregnancy and exercise for all women.
Yep. If your gestational diabetes is able to be controlled with diet and exercise alone, it is called A1 GDM.
Yeah. But if diet and exercise aren't enough, then it's not A1 gestational diabetes, and you're going to need to be started on a medication, and that medication is insulin.
So insulin is an injectable medication that is safe for mom and the fetus because it does not cross the placenta. I know the thought of an injectable medication is a little bit daunting, but again, your doctor, nurse educator, diabetes educator is going to sit down with you and explain all of the equipment and make sure you understand everything that is needed in terms of how to draw up your dose, when you need to take your dose, timing, all of those things. If you need medication to control your diabetes, that is called A2 GDM. Those are just some terms you may see: A1 versus A2. A1, diet and exercise; A2, medications.
One question you may have is if there's any oral medications you could take to treat gestational diabetes.
And the answer technically is yes. However, insulin is the first line recommended medication.
So in addition to all of these things we talked about, blood sugar control, if you have gestational diabetes, there's going to be some other things that are going to play into your care and care of baby during pregnancy. Starting around week 32, your OBGYN is likely going to want you to come in for weekly testing. And these are going to be things like an ultrasound and a non-stress test. And the ultrasound is to look at fluid around the baby and then to see how the baby's growing in size.
Yep, and for the NST, your doctor or nurse is going to hook up a monitor to put it on your belly, and it watches the baby's heart rate for about 20 minutes. Now, studies have not shown an increase in stillbirth in women who have really well-controlled A1 GDM, so your practice may not require this monitoring before 40 weeks. However, it's very practice dependent, so just talk with your doctor about what they prefer.
Another thing you may have heard about or may be questioning is
Yeah.
how does gestational diabetes change the timing of delivery?
And the answer is it depends on what type of gestational diabetes you have and how well controlled it is. For women who have well controlled A1 diabetes, unless they have some other indication, don't need to be delivered before 39 weeks. And most providers will let you go until about 40 weeks and 6 days. If you have really well controlled A2 diabetes, so you're taking insulin but your blood sugars are really well controlled, the recommendation is to make sure you're delivered sometime between 39 and 0 and 39 weeks and 6 days.
Now there is expert opinion supporting early delivery of baby for women who have poorly controlled gestational diabetes.
Yep.
And this is largely to reduce the risk of stillbirth in these women who have trouble controlling their blood sugars while pregnant.
Exactly.
And most of this is thought to be best between 37 weeks gestation and then 39 weeks.
Right.
Reserving earlier delivery between 34 and 36 weeks only for women who fail intensive inpatient management of their blood sugar.
Exactly. It's also very likely that your doctor is going to want to do a growth ultrasound between 34 and 36 weeks just to get an idea of how big your baby is, because we know that women with gestational diabetes are at an increased risk of having bigger babies and having a shoulder dystocia.
Yeah. So if that ultrasound shows that your baby might be bigger than 4.5 kilograms or 9.9 pounds, your OBGYN is likely to discuss the possibility of a scheduled C-section, as well as kind of the risks and benefits of choosing that versus doing a normal vaginal delivery.
It's really important to know that your carbohydrate intolerance usually will resolve with delivery once that placenta is gone. But studies have shown that between 15 and 70% of women who had gestational diabetes go on to develop diabetes, usually type 2, within 30 years. Because of that, the American Diabetes Association and ACOG recommend screening at your postpartum visit, and that's going to be a 2-hour glucose screening test. And then additionally, they recommend screening for diabetes every 1 to 3 years in women who had gestational diabetes.
So that was a really intense, in-depth dive into all things gestational diabetes.
Yes. And so if you find yourself with this diagnosis of gestational diabetes, I know it can feel overwhelming, but don't panic. Your OB team is here for you. There is a team of nurses and dietitians and diabetes educators who do this every day and are there to help you and support you have a healthy pregnancy and learn how to control your blood glucose. I know the finger sticks to check your blood glucose seems like a lot. Insulin injection seems like a lot, but I promise you, you can do it. And by the end of pregnancy, you are going to be a pro at all of those things.
Yeah, so just hang in there. And if you have any other questions for us, please feel free to leave them in the comments below. We try to get to those as best as we can.
Yep.
And please don't forget to hit subscribe so you can catch all the great information we've got planned for our very own 3rd trimester of pregnancy and maybe yours too.
Yes, we will see you next week.
Bye, guys. We're doctors.
But not your doctors.
Anything we've said in this video is for education or entertainment purposes only.
It is not medical advice.
Any specific medical questions you have should be directed to your provider.